So cardiovascular system, we are going to focus here diagnostic test and procedure. So diagnostic, if you ask me, what are the diagnostic test and procedure? Basically, if anybody is diagnosed by the cardiac disease, we need to figure out, or we have to exclude it, right, by some test like EKG or ECG, electrocardiogram, echocardiogram, stress test, or computerized tomography or CAT scan, or MRI is called magnetic resonance. So all of the tests together we call diagnostic test for cardiovascular disease. So the most important diagnostic test we follow is called cardiac enzyme or cardiac marker. So here we are going to find out what are the expected range or duration of the elevated level of the cardiac enzyme. So cardiac marker or cardiac enzyme, they are released in the blood stream in response to ischemia of the heart muscle. If you see this picture, it's called myocardial infarction. So you see the blackening in the apex or left ventricle. This is ischemic change. If the ischemic are not treated, the ischemia in the heart muscle lead to MI or myocardial infarction, and myocardial infarction lead to heart failure or patient will die. So if you ask me why myocardial infarction develop or ischemia develop, if patient have atherosclerosis, means the blood supply reduce, or if the heart blood demand increase or blood supply reduce, maybe because of atherosclerotic change or arteriosclerosis. So when the tissue damage like ischemia, the cardiac tissue release some of the enzyme in the bloodstream in response to ischemic change. There are three cardiac marker or enzyme. They are troponin C, cardiac troponin 1, and cardiac troponin T. Troponin is the most specific for heart. Troponin. Other cardiac enzymes are called CKMB. You see, CKMB or myoglobin. You can see the myoglobin, or go next, CKMB. CK stand for creatinine kinase myocardial muscle, and myoglobin. So this is the cardiac marker or cardiac enzyme, right? So out of all, the troponin is the most specific for heart. There are three troponin: troponin C, troponin 1 or I, and troponin T. So the troponin I should be less than, I said, 0.03 nanogram per liter. So troponin I especially has a high affinity for cardiac injury. It raises within 3 hours and persists for up to 7 to 10 days. So they increase in the blood within 3 hours, and they will be elevated for 7 to 10 days. So in this graph showing, you can see this is X and Y axis. Here is showing the day after the onset of acute MI. Here the showing the limit of the upper limit of the of normal cardiac enzyme. So troponin I said troponin I. This is the troponin here. So they raise after the heart failure or MI or ischemia within 3 hours. They go in the peak, and they should be elevated up to 7 to 10 days. So you see, this is the borderline. They go in the peak and they still elevated up to 7 to 10 days. What about the troponin T? Troponin T, the normal values are low, with troponin I begins basically less than 0.03, and troponin T begins less than 0.2 nanogram or less than 0.2 microgram. Its rates can indicate myocardial cell damage, right? So troponin T should be less than 0.1 nanogram per liter. If myocardial ischemia develop, the troponin T elevated for 10 to 14 days. So troponin T, like troponin I said, elevated for 7 to 10 days, but troponin T elevated for 10 to 14 days. Okay. And another enzyme or cardiac marker we use is called CKMB. So you see, if you compare and contrast CKMB with troponin, they did not pick up like the troponin. They pick little bit less, and they elevated. They also elevated, but not like the troponin. CKMB more specific to the heart, right? More specific CKMB, more specific to the heart than only CK. CK stands for what? Creatinine kinase. And this should be 0% and elevated for 3 to 3 days. You see the picture? They peak here after 1 day or at the 1 day after ischemic attack, and they up to here. So peak 2 to 3 days or 5 days. The other one is called the myoglobin. You see myoglobin and see myoglobin. This one, little bit pick up myoglobin. So myoglobin can be elevated due to the heart damage, or also myoglobin elevated in case of skeletal muscle damage. And this should be less than 90 microgram per liter, and they elevated only for 24 hours. So after 24 hours, myoglobin will be disappear in case of ischemia. So myoglobin actually special type of protein. Myoglobin is an oxygen binding protein found in cardiac muscle and skeletal muscle. The level raises within 2 hours after the cell death with a rapid decline in the level after 7 hours. However, it is not the cardiac specific because myoglobin present in myocardium and also the skeletal tissue or muscle. So they does not specific for the heart tissue. If I ask you which cardiac enzyme is specific for the heart, answer would be troponin, right? So before to go, the other diagnostic test, I want to tell you the cardiac enzyme is most important for MI or ischemic change. There are 3: CKMB, troponin T, troponin I, and myoglobin. So what are the other diagnostic tests for heart disease? One is called just count the CBC, or so in case if the patient has any heart disease like inflammatory disease or rheumatic heart disease, we has to go for complete blood count. Complete blood count included the red blood cell count, white blood cell count, hematocrit, hemoglobin, ESR or electrocyte sedimentation rate, all is included. If our patient has a inflammatory heart disease or inflammatory disease of the heart, that times, if you ask me what are the inflammatory heart disease, answer is pericarditis or rheumatic endocarditis or infective endocarditis. They called inflammatory heart disease. In case of inflammation or infection, if you tell your patient go for lab test, after the lab test, we will get elevated or increased white blood cell or leukocyte. Also, it positive blood culture or elevated ESR. ESR stands for electrocyte sedimentation rate, and also elevated C-reactive protein due to inflammation. if your patient have a inflammatory heart disease, we has to collect the throat culture swab and throat culture positive for streptococcal infection, most common, right? And if your patient has a rheumatic heart disease or infective endocarditis, also he has to count the red blood cell. Red blood cell increase in the condition characterized by inadequate tissue oxygenation. In case of heart disease, most of the time the hematocrit is elevated. If hematocrit elevated, or if patient has a anemia, that times hemoglobin go down. If hemoglobin go down, hematocrit also go down. So in case of anemia, hemoglobin go down, hematocrit go down. But in case of vascular volume depletion, I said, that times hematocrit will be increased, right? So what about the others? Others is called blood coagulation factor. So what are the blood coagulation factor? It is important to discuss here. So an increase in the coagulation factor can occur during and after MI. It is very important, my friend. Patient does not develop MI suddenly. At the beginning, they complain angina. Angina, I said. There are three kinds of angina. Okay. If angina untreated, patient develop MI or myocardial infarction. So I said angina first. Just patient, I come to you and tell, I have a chest pain when I do something. Angina is a three category: stable, unstable, and variant angina. Usually patients say, or stable angina occur with exercise, but when they take rest, angina disappear. Or if patient take nitroglycerin, angina disappear. This is the stable angina. Unstable angina means or occur with the exercise or at the rest. Patient complain the chest pain when they do exercise or when they work, but when patient take rest, angina disappear. It's called stable. But when patients say, my chest pain start with exercise or even during the resting time, and unstable angina increase in duration and occurrence or severity over the time. Another form of angina is called variant angina. Variant angina related to coronary artery spasm, and variant angina also occur during the rest. If angina is untreated, it leads to myocardial infarction. So in our lecture, myocardial infarction, I will explain everything more, but little bit talk here. At least we have to know for NCLEX board what are the risk factor for angina or myocardial infarction? Like male gender, postmenopausal women, hypertension, smoking, hyperlipidemia, diabetes, stress, inactivity, all are the risk factor of develop angina. Now our classes about the diagnostic test. So if your patient have a myocardial infarction, what we have to check? Already we discussed a few minutes ago, cardiac enzyme. In case of MI, the elevated cardiac enzyme, also EKG change, electrocardiogram, like ST segment depression or elevation, T wave inversion or abnormal Q wave. I will show you in our EKG section. If MI is untreated, patient develop heart failure, right? So next in this PowerPoint, discuss about the lipid, serum lipid or cholesterol level, right? Cholesterol level, it is very important for NCLEX board. There are different type of lipid or cholesterol, and definitely for board exam, we have to know the normal expected range. And also, we need to know if cholesterol not treated, what complications start. So they said the lipid profile measuring, when doctor write go for lipid profile, means you has to check for total cholesterol or serum cholesterol. You has to check for triglyceride. You has to check for lipoprotein level. Lipoprotein means HDL or LDL. So lipid profile is used to assess for the risks of developing coronary artery disease. Coronary artery disease, or we have to check the hemodynamic monitoring. Both is important. So I said total cholesterol, basically our target would be less than 200 milligram per DL, total cholesterol I said. What about the triglyceride? So triglyceride should be between 35 to 135 milligram per DL in case of female. But if the man, it should be 40 to 160 milligram per DL. I said triglyceride. Also lipoprotein. So there are two lipoprotein. One is called LDL, means low density lipoprotein. They are bad because they collect the bad cholesterol and accumulate in the heart and develop atherosclerosis and lead to cardiac disease. Increase the atherosclerotic plaque and increase the clot vascular should be less than, and value should be less than 30 milligram per DL. Okay, milligram per DL. So low density lipoprotein should be less than, some books say it, less than 130 30 milligram per DL. LDL is a bad cholesterol, right? But HDL is a good cholesterol. LDL carry or LDL remove the bad cholesterol from heart to peripheral tissue. They work as a scavenger. Scavenger means who cleaning the road, right? They clean the heart. LDL should be more than 55 milligram per DL in case of men, but it should be more than 45 milligram per DL. 45 or 55, like the range is there. Here showing like this is the artery, right? You see the yellow, this is atheroma, means bad cholesterol accumulate. And by time they accumulating and they causes the narrowing the lumen of artery, or they cause stasis. And that times blood does not freely moving and blood causes the clot formation, right? So if atherosclerosis is not treated, they lead to develop ischemia or cerebral infarction, means infarction in the brain, cerebral. They develop myocardial infarction, means MI, or renal ischemia, or intermittent claudication. So it is basically common complication of atherosclerosis if atherosclerosis is untreated or non-treated. So another diagnostic test, hematocrit. I told you this is the, if anybody eat too much meat, the hematocrit level go up. Hematocrit is a amino acid. So if anybody's hematocrit level elevated, it may indicate the risks of cardiovascular disease. Another one is called highly sensitive C-reactive protein. C-reactive protein. So if the C-reactive protein is elevated, it increases the risks of inflammatory heart disease. So here we go. If the C-reactive protein level less than 1 milligram per DL, it is considered low risk. If the C-reactive protein level greater than 3 milligram per DL, patient is under the risk of heart disease. Another important marker are microalbuminemia. Microalbuminemia means albumin is a protein. If albumin is present in the urine, it's called microalbuminuria. When it's present in the blood, it's called microalbuminemia. Basically, if the patient has a diabetic for a long time and diabetic is untreated, usually patient develop microalbuminemia. So microalbuminemia, that described as a moderately increase in the level of albumin in urine. Usually microalbuminemia occur diabetic patient or when the kidney leaks the small amount of albumin into the urine. If a patient has a long-time microalbuminemia, it indicates they have a kidney problem as well. So diagnostic test and procedure in case if your patient have a heart problem, right? We has to also check the serum electrolyte, especially sodium, potassium, magnesium, and calcium level. Out of they all, the sodium is most important. Sodium is the most important, I said. So if the sodium level go less than normal, is called hypocalcemia. If the potassium level is go up or more than the normal range, it is called hyperkalemia. So hypokalemia or hyperkalemia both lead to develop arrhythmias, right? Arrhythmia is it. Usually NCLEX board sometimes asks, in case of hypokalemia, what EKG change take place? In case of hypokalemia, what EKG change, right? So let me read it with you. Hypokalemia causes increase the cardiac electrical instability. So when the potassium level is imbalanced, up either increase or decrease, that times electrical function is unstable, ventricular dysrhythmia develop and increase the risk of digoxin toxicity. Digoxin is a drugs we use for heart failure. So if the potassium is imbalanced, the increase the chance of digoxin toxicity. So if the patient has a hypokalemia, the electrocardiogram or EKG or ECG may show flattened and elevated T wave and appearance of the Q wave and ST segment depression. So this is the normal electrocardiogram we can see. So you can see the positive deflection, positive upright P wave, QRS complex positive upright, and T wave positive upright, and also U wave is shallow. It is the normal EKG. It is electrical event because of contraction and relaxation of the cardiac muscle. But if patient develop the hypokalemia, what change take place? Hypokalemia, I said. Definitely, if you ask me, what are the cause of hypokalemia or what are the cause of loss of potassium from the body? Answer is, if patient has a vomiting or gastric suction or diarrhea or use the potassium wasting drugs like diuretics or poor intake of potassium can lead to hypokalemia. The basic sign and symptom are muscle weakness, leg cramping, fatigue, lethargy, decrease the bowel sound, and also decrease the bowel motility. But here we are going to get the focus on EKG right now. If you see this picture and if you compare with the normal EKG, You can see this is the positive upright first events, P wave. P wave develop because of atrial contraction. QRS complex is developed or occur because of ventricular contraction, right? And T wave is developed because of repolarization or resting phase. If patient develop hypocalcemia, we can see just give a look. The T wave is positive deflection, but here you can see the T wave, shallow T wave, or T wave is almost flattening. So then ST segment here, QRS segment, and this is S and T segment. But you see ST segment is depression on EKG, and also very prominent Q wave, but Q wave is very shallow at normal EKG, but hypokalemia, the EKG U wave is very prominent U wave, right? This is the EKG change. In case of hyperkalemia, if patient have a renal failure or potassium sparing diuretics, or if the high potassium intake or excessive use of salt substitute like potassium or potassium shift is in the burn patient, usually patient develop hyperkalemia, right? If you ask me, what are the signs and symptoms developed because of hyperkalemia? Usually patient complain of diarrhea, irritabilities, or confusion. But most cases, hypokalemia or hyperkalemia, patient develop cardiac dysrhythmia or cardiac arrest, muscle weakness, or paresthesia and numbness. In case of hyperkalemia, we can find the peaked T wave, also very wide QRS complex. It would be very wide. Okay. What about the sodium? Another important electrolyte is called sodium, right? So sodium is important in controlling the contractility of heart. The serum sodium level decreases with the use of diuretics. So hyponatremia, when the serum sodium level decreases, we said hyponatremia. If patient have gastrointestinal fluid loss, or if patient have sweating or use of diuretics or drinking water or excess IV dextrose water, they develop hyponatremia. Most common cause are GIT fluid loss like vomiting and diarrhea. Usually patient present to you with a sign and symptom like lethargy, confusion, and anxiety, and also muscle twitching or headache. And if untreated, they develop seizure and coma. The serum sodium level decrease in case of heart failure or indicating excess water. Excess water. When the sodium level is go up, it is called hypernatremia. Hypernatremia sometimes develop if patient has a water deprivation or excess salt intake, or if loss of the fluid from the body, like insensible water loss or diarrhea, right? Usually, if patient develop hypernatremia, they complain of thirsty, dry, mucous membrane, or postural hypotension, or develop the dyspnea. If patient not treated or untreated, the hypernatremia lead to fatigue, restlessness, or decrease the level of consciousness, or disorientation and convulsion. Other most important electrolyte we have to check, this is called calcium, right? If the calcium level low, it's called hypocalcemia. If calcium level is too high, it's called hypercalcemia. Hypocalcemia can cause ventricular dysarrhythmia, or in EKG, we can see the prolonged ST segment or prolonged QT intervals. If hypokalemia is not treated or untreated, they lead to develop cardiac arrest, right? I have one class recording in my YouTube channel about the electrolyte. I like to request, if you have time, you should listen it. I explain everything very well, and I have a note up there. It is very important. If I ask you what are the cause of hypocalcemia, we have to know. The most common cause of develop hypocalcemia are surgically remove of parathyroid gland, because parathyroid gland release the calcium. So also other condition like hypoparathyroidism or acute pancreatitis, hyperphosphatemia or thyroid cancer, hypomagnesemia or alcohol abuse lead to hypocalcemia. What are the most frequently questions asked by NCLEX board? Usually, they ask what are the sign and symptom of hypocalcemia? Super important for NCLEX board. In my sign symptom of abnormal electrolyte, I explain everything, but I want to recap it. It is super important. The sign and symptom of hypokalemia are numbness and tingling sensation in extremity and around the mouth, muscle tremor, or cardiac dysarrhythmia. Dysarrhythmia means heartbeat not normal, either less than 60 or more than 100, either bradycardia or tachycardia. Hypocalcemia develop positive trousseau sign and positive chopstick sign. Very important for board exam. If hypocalcemia untreated, they lead to confusion. Hypercalcemia can cause the shortening the HT segment and wide T-waves. If hypercalcemia untreated, they lead to AV block, means arterioventricular blocks. They develop tachycardia or bradycardia. If you ask me what are the cause of hypercalcemia, the most common cause are prolonged immobilization or some medical condition like hyperparathyroidism or malignancy of the bones. If patient has a hypercalcemia, increase the risk of fracture the bones. The common sign and symptom of hypercalcemia are lethargy, weakness, anorexia, nausea, vomiting, and constipation. Too much calcium causes constipation. Also, too much calcium have a polyuria or hypercalciuria developed. Another question sometimes NCLEX board asks in case of another question sometimes NCLEX board asks if the hypercalcemia patient develop the pathological fracture of the bones. Super important for our NCLEX board exam. The last electrolyte is here are phosphorus level, right? Phosphorus level is important. We have to know about this. So phosphorus level should be interpreted with the calcium. So if the calcium level is up or go down, the phosphorus level also alteration or change, right? So phosphorus level should be interrupted with calcium level fluctuate when, because the kidney retain or excrete one electrolyte in an inverse relationship with others. What does it mean? If calcium level go up, phosphorus level go down. If calcium level go down, phosphorus level go up. It is inverse relationship, I said. What next? Next is magnesium. Important. Let me read it with you. A low magnesium level can cause ventricular tachycardia. What does it mean, ventricular? You must know that tachycardia means excess heartbeat. Excess heartbeat when produced from ventricle is called ventricular tachycardia. Or when more than 140 or 200 beat, fibrillation or fluttering. Magnesium level when increase, we can see some change in echocardiogram. Electrocardiogram change that may be observed with hypomagnesemia include the tall T-wave and depressed ST segment. A high magnesium level can cause muscle weakness, hypotension, and bradycardia, right? So When magnesium level go up, it is called hypermagnesiemia. Some medical condition like renal impairment or diabetic ketoacidosis or dehydration, hypothyroidism, or some endocrine disease like Addison disease can cause hypermagnesiemia. If patient have high magnesium level or hypermagnesiemia, they develop some of the sign and symptom. This is called neuromuscular depression or cardiac muscle depression or arrhythmias. So increase the magnesium level can cause central nervous system depression, lethargy, hypotension, and bradycardia. Right? Central nervous system effect. Electrocardiographic change that may be observed with hypermagnesiemia include the prolonged PR interval and widening QRS complex. So if I go back in this graph, this QRS complex should be widened and PR interval should be prolonged, right? So on the other hand, if the magnesium level go down, is called hypomagnesemia. Example I want to share with you, excess loss of magnesium from the gastrointestinal tract or nasogastric suction or diarrhea, fistula, or long-term use of certain drugs like diuretics, aminoglycoside antibiotics can lead to develop hypomagnesemia. Hypomagnesemia is like as hypermagnesemia. Both can cause neuromuscular irritabilities or tremor. Especially hypomagnesemia increase some reflexes. They develop convulsion or cardiac arrhythmia. So hypercalcemia, hypocalcemia, hypermagnesemia, hypomagnesemia all develop cardiac arrhythmias. Even hypokalemia, hyperkalemia also develop cardiac arrhythmias. But most important is here, hypomagnesemia develop the tetany or psychosis. Few minutes ago, I told you the hypocalcemia. Hypocalcemia, I am going to recap it, causes the positive chopstick sign or Trozier sign. Same as hypomagnesemia also causes positive chopstick sign and positive trouser sign or trouser sign. For easy, I said trouser sign. Both is same. So, right? If you read, compare and contrast, it is easy to remember. So now go next, diagnostic test. What we need for board exam. That one is called blood urea nitrogen and blood glucose, and most important is called BNP. BNP stands for B type natriuretic peptide. Very short, let me explain it. Blood urea nitrogen, shortly BUN, right? So blood urea nitrogen is elevated in heart disorder that adversely affect the renal circulation, such as heart failure and cardiogenic shock. So BUN is altered if heart problem or if renal problem, right? If heart problem or renal problem. So if you feel your patient has a heart problem, definitely we have to check the vital sign like heart rate, respiratory rate, blood pressure, and temperature. It is our responsibilities. Then we have to check the CVC, means hematological values like complete blood count, RBC, WBC, hemoglobin, and hematocrit. Then we go for serum electrolyte, what we finished a few minutes ago: sodium, potassium, calcium, magnesium, and phosphorus. Now I said blood urea nitrogen. So I want to share with you blood urea nitrogen, naturally shortly called BUN. The normal range is 7 to 20 milligram per dl. So BUN level is altered or elevated in case of heart disorder or kidney problem. If patient has a kidney problem, we have to check the serum creatinine. If patient has a heart problem, we also check the blood chemistry like lipid profile, right? Triglyceride, cholesterol, everything. Blood glucose. Everybody know if patient is a diabetic, blood glucose level go up, right? And usually the blood glucose is 70 to 110 milligram per dl. Acute cardiac episode, not talking about the diabetic. The cardiac episode can elevate the blood sugar level as well. So if your patient has a diabetic for a long time, the chance of develop the heart disease. Another most important marker are BMP. BNP stands for what? B type, natriuretic peptide. So BNP is released in response to the arterial or ventricular stretch, ventricular tissue or arterial tissues. And it is severe as the marker of the heart fail or heart failure, right? So BNP level should be our target less than 100 nanogram per liter. If the BNP level is more than 300 or some books said 400, it indicates the heart failure. What else? Then go. So another diagnostic test we have to do the chest X-ray film. So radiography of the chest is done to determine the size, shape, and position of the heart. So sometime in heart disease, the cardiac shadow is getting bigger and is called cardiomegaly. So you can see in this chest radiography or chest X-ray film, this is the shadow of the heart. This is the ventral apex great vessel is there, right? This is the heart shadow. If patient has cardiomegaly because of the heart problem, right, like hypertrophy, so that times we can see the bigger heart. So it is very important to know what are the intervention we have to teach our patient before go for chest X-ray. Like prepare the client for chest X-ray film and explaining the purpose and procedure. And also remove the jewelry before to take the chest X-ray. Ensure that the client is not pregnant. Even you have to make sure the patient do not have any pacemaker. Another most important test we do for cardiac patient, this is called EKG, right? Or shortly, or it is called ECG. EKG means electrocardiogram, electrocardiography. Electrocardiography is a process of the process and electrocardiogram. So it is the graphical representation of the ventricular events, right? So because it is a graphics of voltage versus the time of electrical activities of the heart. So as if I make easy, let me see if the graph here. So like here, graphical representation, like this is the paper's graphical representation of the cardiac events. This is the common non-invasive, you see, non-invasive diagnostic test record the electrical activities of the heart and useful to detect the cardiac arrhythmias or to detecting any location and extent of myocardial infarction, cardiac hypertrophy, and also for evaluation of the effectiveness of cardiac medication, therapeutic. So by electrocardiography or EKG, we can find out some disorder like sinus bradycardia or sinus tachycardia. We can exclude atrial fibrillation. We exclude ventricular fibrillation. We have to exclude by ventricular tachycardia or even asystole. In my EKG classes, I will show you some graphical representation of every disorder. And it can help you to understand and answer the NCLEX question. So if your patient has to do or have to do the electrocardiography, what are the intervention you have to do or you have to tell your patient, right? In the picture, you can see the EKG machine portable. It is here it is electrode. To determine the client ability to lie still, lie down on the bed. advise the client to lie down still and breathe normally, right? And also reassurance the client that our electrical shock will not occur. It is not harmful. Also, keep document any cardiac medication that if the client is take, we has to keep the documentation after take the history, right? The other two tests we has to do in the cardiovascular diagnostic test. This is called Holter monitoring. It is important for the NCLEX board. Very important, Holter monitoring. So keep in mind, Holter monitoring means EKG, but EKG we have to do for 24 hours. This is the painless 24-hour EKG. You have to teach your patient, do not get wet, because you have to put the electrode and carry this machine 24 hours. Don't take shower, and keep a diary of activities. So 24 hours, what you did, you have to mentioning, right? So here, let me read it. Holter monitoring in this non-invasive test, like the chest X-ray non-invasive, EKG non-invasive, Holter monitoring non-invasive, where a Holter monitor and electrocardiographic tracing is recorded continuously over 24 hours or more, while the client perform activities of daily living. Holter monitoring identify dysrhythmia if they occur and evaluate the effectiveness of antidiuretics or pacemaker, right? And sometimes some of the patient has to use the pacemaker as well or dysrhythmia. So we can find it out what are the dysrhythmia and what are the medication effect. Like patient has bradycardia, means heart rate less than 60. Patient explain the symptom. If patient symptom, we give them administer the atropine. After the atropine, what are the effect of the heart? We can observe. Like patient using the pacemaker, what are the electrical event change because of pacemaker? We can see by Holter, right? So you know what is pacemaker. Pacemaker means the device, they can help you to produce the impulse in the heart. Pacemaker basically provide the electrical stimulation of the heart when natural pacemaker in the heart does not maintain the proper rhythm. So what are the intervention? Reinforce instruction to the client to resume the normal daily activities and to maintain a daily documentation activities and any symptom that may develop for correction to the electrocardiographic tracing. Reinforce the instruction to the client to avoid the tube bath or shower because they will interfere with the electrocardiographic recording, right? Something like, sometimes we do the electrocardiogram in the brain, that is called EEG, means electroencephalography for the brain, but EKG for the heart. So if we analyze the electrical activity of the heart, it is EKG, electrocardiography. If we analyze the electrical activities of the brain, it is called electroencephalography, right? So what else? Electrocardiography. So now echocardiography, echocardiography. Echocardiography is a non-invasive procedure based on principle of ultrasound and evaluate the structural and functional change in the heart. So echocardiography can see any structural defect or functional defect in the heart, right? So heart chamber size should be measured. Ejection fraction can be calculated. Low gradient across the valves is determined. Another test is called transesophageal echocardiography. Transesophageal, my friend. So by the transesophageal electrography, we can detect the blood clot, if any. We detect the tumor in the heart, if any, or we can find out any kind of valvular problem by transesophageal electrocardiograph, like this. This is the device passing through the esophagus, right? It's called transesophageal echocardiography, shortly called TEE, transesophageal echocardiogram. So by this technique, we can see the heart muscle. We can see if any clot is there, can detect it. If a tumor there, can detect it. If any valvular dysfunction, malfunction, malformation, we can find it out. So usually this procedure takes 10 to 30 minutes. The procedure time 10 to 30 minutes. You see a tube is swallowed, going like this. The tube is swallowed, this man swallowed. An end is positioned in the esophagus up to this, behind the heart. This is the heart. It is come up to esophagus and take the picture. The heart is examined from different angle when you use this transesophageal echocardiogram. So it is very important as a RN or LPN, what are the pre-procedure and what are the post-procedure? Pre-procedure basically tell your patient not to take any food 6 hours before the procedure. Place the client on left side. and also IV sedation or throat anesthetics are used. After the procedure or post-procedure, we tell the patient not to take the food or orally food next 2 hours. Also, not driving for 12 hours. Super important for NCLEX board. The other one is called exercise electrocardiographic test or trace test. In this picture, you can see a man put the electrode or EKG and he is walking over the treadmill, right? So here in trace test or echocardiogram during the exercise, we use a dye injection which act as a trigger. And also there are some camera take the picture of the heart, and the area that appear the dark indicate inadequate blood flow. And also other type of trace test we use. There are two types of trace test. One is called trace test because during exercise or treadmill, and it's called selenium scan. Two types. Here the exercise. This is non-invasive test. The heart, study the heart during the activity and detect and evaluate the coronary artery disease. Treadmill test is the most commonly used mode of trace testing. If the client is unable to tolerate exercise, an intravenous infusion of dipyridamole or dobutamine hydrochloride is given to dilate the coronary arteries and stimulate the effect of exercise. Before the test, patient or client may need to be nothing by mouth for 3 to 6 hours. So as a LPN or RN, what we have to tell our patient or teaching to the patient? Here, pre-procedure intervention, reinforce the instruction to the client to wear a non-constructive or comfortable cloth, and also supporting rubber shoes. Reinforce the instruction to the client to notify the healthcare provider if they have any chest pain or dizziness or shortness of breath. We have to inform healthcare provider. After the procedure, we have to intervene or reinforce the patient, instruct the client to avoid taking a hot bath or shower for at least 1 to 2 hours. So another diagnostic test we use called magnesium. So magnetic resonance imaging, shortly called MRI, right? So magnetic resonance imaging, when you tell your patient for this, it is very important for pre-procedure teaching. First of all, let me see what it wrote here. The MRI is a non-invasive diagnostic test that produces an image of the heart and blood vessels, right? It provides the information on the chamber size and thickness and valves and ventricular function and blood flow through the blood vessels and coronary arteries. So if your patient have to do the MRI, what you has to teach them? Pre-procedure intervention, right? It is very important. We do MRI for brain, we do MRI for abdomen, chest, for cardiovascular system, right? Every time you has to tell your patient, you has to assess your patient for allergy to iodine. Super important. Assess the allergy to iodine if contrast will be used. Contrast, sometimes non-contrast, that is important. Also, here you can see evaluate the client for presence of pacemaker. So if patient have a pacemaker, they're not allowed to do this or implant the items that present a contraindication on the test. Ensure that the client has removed all jewelries, metallic object like jewelries, cloth, or watch. Ensure that the client remove all credit card. Inform the client that he or she may experience the claustrophobia because the scanner, it look like a closed chamber. So assess for the history of claustrophobia or have the patient remove all jewelries. Make sure the patient does not have any metallic implant. I'm recap it. Metallic implant means pacemaker, orthopedic joint, artificial heart valves, or IUD or aneurysm clip. We have to remove it. So another exam or study diagnostic tools we use is called electronic computer tomography. So by this determined whether the calcification are present in the artery or not. Coronary artery calcification, right? By this we can find it out. Therapeutic, diagnostic, and management procedure. One of the most popular procedure, the coronary angioplasty, right? Coronary angioplasty, it is the invasive procedure, non-surgical technique. Basically, coronary angiogram, sometimes some books said cardiac cath. Coronary angiogram is an invasive procedure used to determine if patient has any coronary artery blocking or blockage or narrowing. And by this procedure, a catheter is inserted into the femoral artery and they go up to the heart, right? So here I'm talking about the coronary angiogram. SARN or LPN, it is very important pre-procedure education to the patient and post-procedure education. Pre-procedure, we make sure patient NPO, means nothing by mouth, 8 hours prior to the procedure, and also access for allergy to iodine. Also assess the kidney function. So if patient kidney does not work well, that means we will not use the dye or iodine. We will not use. How you have to function the check the kidney function? Just check the BUN and serum creatinine. It determines if the kidney can excrete the dye. After the coronary angioplasty, what you have to teach your patient is called post-procedure. Check the insertion site for bleeding, or check extremity distal to puncture site. We have to check the pulses, capillary refill, temperature, and color. Keep in mind, after coronary angioplasty, one of the techniques called percutaneous transluminal coronary angioplasty is one of the type. After the procedure, take the vital sign every 15 minutes in first 4 hours. Then every 30 minutes next 2 hours. Then every hour next 4 hours. And during this time, patient has to lying down on the bed or flat on the in bed for 4 to 6 hours after the procedure, right? So percutaneous transluminal coronary angioplasty in or another test we use is called percutaneous transluminal angioplasty. The pre-procedure and post-procedure is important. Okay. So another procedure we use is called percutaneous transluminal angioplasty. Discontinuation, actually. I can show you here. If sometime the patient develop some complication like arterial dissection or rupture or embolization of the plug fragment or spasm or acute MI. So like this is the artery in the heart, maybe this artery is narrowing or atheroma develop. This is you see the stent passing, then dilated the arteries and the mesh is left there. So percutaneous transluminal pre-procedure, I want to recap it. Similar to the pre-procedure of intervention of cardiac catheterization, we have to inform healthcare provider may prescribe the pre-procedure medication sometime, include acetyl salicylic acid, or reinforce the instruction to the client that chest pain may occur during the balloon inflation. If you see in this picture, it is showing the stent insertion in picture number 1, then stent expand. The narrow blood vessel expands as well. The stent remain in the coronary arteries, so it is dilated, also known as balloon angioplasty or angioplasty, or is called PCI, means percutaneous coronary intervention. So PCI, the procedure is open the coronary arteries and perform within 3 hours of onset of MI symptom. The PCI is a 3 types. One is called arteriectomy, other is called placement the stent, and PTCA. This is the PTCA, means percutaneous transluminal coronary angioplasty. So what are the post procedure? Similar to the post procedure of intervention following the cardiac catheterization. Admin anticoagulant, antiplatelet as prescribed. Intervention nitroglycerin may be prescribed. So post-procedure continuation here, carrying the fluid if not contraindicated to enhance the renal excretion of dye, and also reinforce the instruction to the client in the administration of prescribed medication, assist the client with planning the lifestyle modification. In the picture number 1, called the balloon trapped catheter in position the artery. So in the picture number 2, this is the, you can see yellow color, the plug formation, the uninflamed balloon. This is the uninflamed balloon, this one. Picture number 3, the balloon is inflected. The narrow artery going to expand. Picture number 4, the balloon is removed and artery is left unoccluded, right? So nursing care is important in case of the PCI or PTCA. Also, and because sometimes patient develop complication, definitely we has to prevent the complication. The nursing care, all what we have to do for, care of angiogram, we has to do same thing, pre-procedure, post-procedure, same, like check the insertion site for bleeding, check the extremity, like pulse check, capillary refill, or temperature and color, and vital sign every 15 minutes, first 4 hours. Then every 30 minutes, next 2 hours. Then every hour, next 4 hours. I said the PCI or PTCA, the care of the patient should be same like coronary angiogram. Sometimes patient develop some complication because of PCI, means percutaneous coronary intervention, or PTCA, percutaneous transluminal coronary angioplasty. What are the complications? Like arterial dissection or cardiac tamponade. Cardiac tamponade. What is cardiac tamponade? Cardiac tamponade means accumulation of the fluid in pericardial sac. Usually patient present with hypotension or muffled heart sound or distended jugular vein or paradoxical pulses. It is a complication. Sometimes patient develop bleeding or embolism, also retroperitoneal bleeding or restenosis of the vessel. These all are the complication. So, as I told you, the PCI or the procedure to open the coronary artery perform the there are three types. One is the coronary artery stenting. Okay, coronary artery stenting is one type. The other type is called arteriectomy, means removal of the plug in the vessel. So in this picture, the plug is removed and reconstruction. This is called arteriectomy. Removal the plug from coronary artery by use of a cutting chamber on inserted catheter. Another type. And another type is called, already we finished the PTCA. PTCA means this one. PTCA means Percutaneous Transluminal Coronary Angioplasty. In this procedure, inflecting a balloon, this is the balloon inflect, within the arterial lumen. So this is the three types. So coronary artery bypass grafting, shortly called CABG, right? Coronary artery bypass grafting. This is the surgical or surgery to bypass one or more coronary arteries due to the blocking or persistent ischemia. So, like example, the artery, left coronary artery or right coronary artery, if the blocking, like this picture, this is the left coronary artery, right? This one, and this is the right coronary artery. If any blocking of left or right artery, because heart is supplied by the two great artery, left coronary and right coronary. If any blocking of these two arteries or persistent ischemia, that times we use the bypass. Like this is the bypass. Directly internal, this is the branches from arch of aorta. Bypass is distributing the blood to the ventricle. Here is showing the arch of aorta, bypass saphenous vein graft. There are three branches showing distribute the blood to the right atria, left ventricle, and intraventricular septa, saphenous. So saphenous vein, like this, vein often used. So you can cut the saphenous vein from your body and then from the thigh and then put in the heart. Saphenous vein often used. And patient core temperature lower to decrease the metabolic and also demand during the procedure. What are the most important from here, I can read saphenous vein, internal mammary artery, or other artery may be used to bypass. So saphenous vein is collected from the thigh or mammary artery used to put here for the bypass. Coronary artery bypass graft is performed when the client does not respond to medical treatment, right? Or if the vein is severely blocked or occluded. So what are the nursing care for coronary artery bypass grafting? We have to monitor the blood pressure, like the hypertension can cause the bleeding from the graft, or hypotension can cause collapse of the grafts. So it is important to monitor your patient. Or monitoring the chest tube over 150 ml per hour can indicate hemorrhage or notify healthcare provider, right? So it is also important the patient teaching. So we have to treat angina with sublingual nitroglycerin. Also tell your patient not to smoking and consume the heart healthy diet, not excess fat or junk food. Also participate in cardiac rehab program. Very important, right? So inform the client that endotracheal tube will be placed and that he or she will be unable to speak during the procedure, right? And another coronary artery bypass grafting is called transfer to the client from cardiac surgery. Okay, so after the procedure, we have to transfer the patient to ICU or surgical unit. For monitor the vital sign, level of consciousness, and also peripheral perfusion. Also, it has to monitor for dysarrhythmias, auscultate the lungs, and monitor the respiratory status, encouraging the client to spelt the incision, cough, and deep breathing. Monitor the temperature and white blood cell count. Means you have to save the patient for infection, right? Provide adequate fluid and hydration. What else? Transfer the client from cardiac surgical unit continuation, monitor the suture line, chest tube insertion site, monitor the sternal suture line for instabilities which may indicate the infusion. Guide the client for gradually resume the activities, right? Monitor the client for tachycardia, postural hypotension, fatigue. Also discontinue the activities if blood pressure drops more than 10 to 20 millimeter of mercury or pulse increase more than 10 beat per minute. Another bypass grafting is called peripheral bypass graft. One is the coronary artery bypass graft, other is called peripheral bypass graft. At least you have to know a little bit. So peripheral bypass graft means surgery to restore the blood flow to the extremity due to peripheral arterial disease, shortly called PAD. If patient have a peripheral arterial disease, we have to advise them for peripheral bypass graft, right? So it is important